Okay, so my case is percutaneous intervention in bald aortic arch because of Takayasu aorta arthritis. My patient PD, 16-year-old young girl, was presented in July 2012 with chronic diffuse headache of 1 year duration, dizziness while walking from last 1 year, photophobia which got relieved with analgesic from last 1 year, and decreased vision in the left eye. Ophthalmological examination did show hypotensive retinopathy. On examination, absent bilateral upper limb pulses and also carotid pulses. Blood pressure in both upper limb was not recordable. ESR was 43 millimeter in first hour. C-reactive protein was positive, for which she was put on steroid in May 2012. A CT scan did show total occlusion of all the three major arteries from the aorta. If you see the right brachiocephalic to certain part is visible after the origin. And intracerebral circulation and distal part of all the three major arteries are filling via the collaterals. A fundus examination was suggestive of hypotensive retinopathy with attenuation of arterial tree. So on 28th of July, she was taken for the angiogram, which showed normal coronary and total cutoff for all the three branches. Right brachiocephalic is visible in another view, which is having 100% block. So she was taken for the percutaneous intervention. A Conquest Pro wire could cross from the right brachiocephalic to the right subclavian artery. It was dilated with a 2 into 15 millimeter balloon, and flow could be achieved in the right carotid, vertebral, and also subclavian. Distally in the subclavian, there was some dissection. Both the carotid and also vertebral were wired with the coronary guide wire. Carotid and also the subclavian were dilated with 6 into 20 millimeter balloon. There was a long dissection in the right subclavian artery. At this moment, the result was satisfactory, flow was good, so procedure was stopped. 3 weeks later, she was again taken. There was a good flow across the carotid and vertebral, also subclavian artery. A 7F Cook sheath was taken, and then there was a dissection flap in the subclavian artery, which got occluded after giving some contrast into the brachiocephalic artery. The subclavian dissection was of a log segment. If you see, it is extending from this point till the origin. It was crossed from the right brachial and also from the aortic side. It was dilated with 3 into 9 and then 7 into 40 millimeter balloon. And then 2 stent, 7 into 150 millimeter self-expanding stent from the right brachial, and 7 into 120 millimeter self-expanding stent from the aorta to the carotid were deployed. Both the stents were post-dilated with 7 into 40 millimeter balloon. And then good flow was achieved across the right brachiocephalic, subclavian, and carotid. There is a flow in the vertebral as well. She was taken after 6 weeks for the left subclavian intervention. So diffuse disease of the right left subclavian from the origin, and it's a long segment. From the integrate approach via the aorta, the lesion could not be dilated even with the balloon support and Conquest Pro guide wire. So a thermo wire from the left brachial was taken. It could cross, but then it was subintimal. It was dilated with the 5 into 40 millimeter via left subclavian, left brachial. Left brachial and also subclavian was dilated. Still, it was not into the true lumen at the aortic end. Ultimately, another balloon from the aortic side, 3 into 15, was dilated into the subclavian, and a wire from the aortic side could cross the lesion. 8 into 100 millimeter and 7 into 100 millimeter, 2 self-expanding stent from the ostium to the distal part of the brachial artery were deployed, post-dilated with 7 into 40 millimeter balloon. and a good flow was achieved across the left subclavian. Day 2 post of left subclavian is stenting patient and a pain in left shoulder, local tenderness and also fever. Ultrasound was normal, blood culture did show pseudomonas positive, started on antibiotic. Pain persisted, day 9 repeat ultrasound shows some collection across the left subclavian. After its origin, query hematoma. Taken up for check angiogram on day 12. So a left subclavian pseudoaneurysm was there. Distally the flow was good and brachial was well palpable. It was treated with 9 into 40 millimeter fluency stent, successfully excluded. At follow-up, patient was discharged on aspirin and clopidogrel and also on prednisolone. 3-month follow-up, headache got improved, no dizziness, vision also got improved. A repeat CT scan at 3 months follow-up showed a good flow across the subclavian and also carotid.
You have 30 seconds.
There is improvement in retinal circulation. Fundus examination had improved circulation pre and post intervention. Ultrasound did show, duplex ultrasound did show the patent stent of the right brachiocephalic. So in conclusion, Takayasu aorta arthritis having 100% occluded are 3 major arteries, successful percutaneous intervention of right brachiocephalic, right common carotid, left subclavian was done. Post-intervention patient had a pseudoaneurysm which was successfully treated and 6-month follow-up is uneventful. Thanks.
Rachel, you did a very difficult case.
Thank you.
And I agree that you had to stent this inflammatory disease. We are not used of such a patient in Europe, and you have many more in India. The problem for this case, in my concern, is this infection. Is it an internal or external infection? And is it safe to put a cover stent in this infected pseudoaneurysm?
Yes, day 2 there was some problem. I did put the antibiotic coverage was given and later on the blood culture was negative. Patient is doing well. Yes, you are right. In case there is infection at the local site, it should not have been put.
Michel, I think because of your Indian experience, you have treated with the Indian colleague such a patient. Do you use to stent this kind of patient?
I think you don't have any other solution because in France or in Europe now we can place a multi-layer stent for this pseudoaneurysm. Maybe it's better because you can't cover any branch, but not in India. At the present time. So it's not the same problem, but in that case, I think that's the unique solution to treat the pseudoaneurysm.
Any question from the floor?
Dr.
Yes,
Rajesh,
I have a
one
question here.
I also have one
A question here, and then you speak.
Yeah.
Short
Actually,
question.
Yeah, sorry. Takayasu arthritis is a pen arthritis. And it's not intimal disease that you have elastic media and adventitia to the gist. So rupture is very common. Rupture, dissection, everything is very common. So here what we follow, we don't go high pressure, don't dilate, rather we use undersized balloon, under dilatation, self-expanding stent, just insulate the stent rather than going high pressure. Otherwise what you did is well, but only thing is that you used 7 millimeter balloon, that is the region for rupture. I think that time you have not seen it, later on it developed. So in arthritis, very careful, more adrenaline release
So
while dilating with the balloon. Yes.
What is your question?
Question is not, this is comment.
It's a comment. Do you have
Here I want to emphasize that this was the point where I was not able to go antegradally and retrogradally. So here the balloon dilatation was done, and you are right, because of pen arthritis and balloon dilatation at that point, possibly the thing got weakened down and later on the aneurysm was developed. I still feel it's not infective etiology for the pseudoaneurysm. It's because of iatrogenic injury. The patient had no problem. Incidentally, she had no fever, possibly because of the upper limb pain or inflammatory reaction. But then, inadvertently, I had no pseudomonas in the blood culture, and for which appropriate antibiotic was given. I personally feel there was no active local infection because at 6-month follow-up, patient is doing well.
Rashesh,
So I think if you are
you
doing
have
this,
two other questions, sorry. One from the panelists
Dr.
and one
Rajesh,
from Dr. Das.
in the first sitting, you did the right carotid. In second sitting, right subclavian. In the third sitting, left subclavian. Could you do it in the one sitting?
Contrast load is a concern, and it's a long procedure. I thought it's better to have a stage. At the first stage, I did the balloon dilatation and then stopped because stenting doesn't have a good result for Takayasu aorta arteritis. But then on follow-up, I found that the carotid and also subclavian is somewhat weaker. I thought, let's check it, whether everything is fine or not.
When you saw the dissection in the right subclavian, you never thought of putting a stent then and there?
Yes, but then flow was good. At that moment, flow, if you see, even at second sitting when I took the patient, the flow was good. And then I was wiring the carotid, all of a sudden it got occluded.
Thank you.
Okay, thank you.
gone hardly any flow in the brain, and suddenly you will increase all the flow, and hyperperfusion syndrome will occur in this case. So it is better to stage, and what he has done is right.
Okay.
So, last question, because we are running out of time, I'm sorry, from Dr. Das. Short question, short answer.
2 questions. Yeah.
No. one and a half.
Now, we keep hearing very interesting short-term results of this Takayasu disease. Do we know anything about the long-term outcome of this intervention?
George Joseph from India has published a lot of paper on long-term stenting in Takayasu aorta artery. I personally don't have my own experience of long-term stenting for this disease.
Which is how long?
Usual consensus is to go ahead in the stage manner with lower balloon size, and gradually you can increase. And it's only the bailout situation where
Does
one has to
it
go
need
ahead and put the stent.
reintervention? Does it need reintervention after about, say, 1 year or 2 years or so?
Yes, it depends on the symptomatology and the non-invasive tests like say
And my final question, sorry.
Second question.
Yes. That what is the natural history of this disease? Is it self-limiting, or is it going to go on, and are you going to treat them on steroid all along?
It's a variable. Clinical course is variable in Takayasu aorta artery. It depends on the activity, and sometimes you do an indolent course for long years, and the patient is relatively okay, while the active disease with, like in this particular case, with the ESR and C-reactive protein on the higher side, one has to go ahead with the steroid therapy at least for the 6 months, and possibly cytotoxic drugs as well in case it's not responding.
This could be a whole session. And what you've done is very good for the fellow. You just give an approximation of the disease. It's good, but this could be a world congress. So we have to stop, and thank you very much anyway.
Thank you.